Thank you for being here. Sincerely, thank you very much. I'm sorry you don't consider this trip a vacation, since you
It is kind of.
kind of vacation, a little ways, but you're telling your personal story makes a difference. It really does make a difference. I'm going to ask you a few things about it in a minute. What a panel. What a great panel. Thank you all for being here. Dr. Douglas, thanks for telling your personal story your perspective as a physician. It really is meaningful. You mentioned that to manage his diabetes, your father was prescribed Jardiance, which he was unable to afford. I think we have a chart on Jardiance. As you can see from the chart, Jardiance manufacturers steadily raised the drug's price over the last 5 years, from around $450 to nearly $600 for a 30-day supply. Your father lived through this. Under the Inflation Reduction Act, Medicare is finally able to negotiate the price it pays for certain drugs, including Jardiance. And the Biden-Harris administration was able to negotiate the price for Jardiance down to $197 a month, a 66% discount over the high price your dad faced. Tell me what that price reduction you think will mean to your patients.
Well, in short, Senator Durbin means saving lives. I mean, people who have access to the medications that they need because they are affordable and within reach means that their conditions such as Jardiance, which is utilized to manage diabetes as well as some other comorbidities as well, means that they have their blood sugars in control. They stay out of the hospital. They don't have complications associated with diabetes like strokes, heart attacks, peripheral vascular disease. Ultimately, it means that we keep people out of the hospital. We keep people from the morbidity and the mortality associated with diseases like diabetes.
So I'm going to ask you a question about the medical profession and vis-a-vis this issue. And maybe you'll feel comfortable answering. If you don't, just say so. But it strikes me that there are a handful of drugs which we are bombarded with when it comes to advertising. You just can't watch a football game or, frankly, anything on your television without getting an ad for a new drug, or many times drugs you know pretty well. Yeah. The fact that we can pronounce and even spell Xarelto at this point is proof positive that we've certainly been trained with all these ads. I'm assuming, and you tell me if I'm wrong, that the pharmaceutical companies have basically decided if we can convince the ultimate consumer to go into the doctor's office and say, I need Xarelto, I need Wegovy, whatever it happens to be, that the doctor is going to prescribe that, as opposed to questioning whether or not it's necessary or whether there's a affordable generic. Is that true?
Yeah, I mean, I think that is the strategy. Not only do they advertise directly to physicians to encourage us to prescribe these medications, but they also encourage patients to go in the clinics and the hospitals to ask for these medications. For example, the drug that we've all been talking about today, Ozempic, we're constantly as physicians being bombarded with questions about their ability to get on Ozempic, just to find out that the patients can't afford Ozempic. I think the list price for Ozempic is around almost $1,000. And so they certainly, this is certainly a strategy, I believe, from the pharmaceutical industry to encourage patients to ask for the medications that they see on the television screen. And oftentimes, patients aren't even aware that these medications are applicable to their situations. And we as physicians have to educate them and tell them why, this medication is not appropriate for your condition.
Let's take Ozempic and look at some numbers. Novo Nordisk sells it for $71 in France, $59 in Germany. The United States, they charge patients $969, and the price is only going up. And I can understand the demand are coming from the consumer side. Anything that is reduction in weight, which doesn't involve strict adherence to diet or exercise. People have been looking for that miracle cure for a long, long time. And it's going to create an ethical issue for us, too, unless we bring the price down to an affordable level in terms of the fact that weight reduction in and of itself, I think, is beneficial in almost every circumstance. Mm-hmm. And so how do you react to that?
Well, my concern is, again, for those patients who Ozempic is not appropriate for. There's certainly conditions and situations where medication is not the right answer to address weight reduction. In some cases, surgery is more appropriate for patients with high BMI scores. And so my concern is that those patients who come in asking for the medication, often for some of them, that medication is not applicable to them. And then for the patients who it is applicable to, most of them can't afford to even take the medication for us to prescribe it to them. So I think that there's certainly, I think it's issues on both sides.
Dr. Sandsmark, let me ask you a question that I raised earlier with the first panel. What's going on with Walgreens? Why is it when you go in there, you have to wait in line to get a prescription filled? I had to return a third day to get a prescription filled at a Walgreens smack dab in the middle of Chicago. And you better pick the time of day when you're coming. If it's any time near the end of work day, the lines are just unbearable. And here we have a situation where they're saying, well, the answer to this from Walgreens' corporate perspective is we're going to have to start closing drugstores. Closing drugstores, how does that may solve a corporate financial problem, but it certainly doesn't address the basic problem of people waiting in line forever and ever to have a prescription filled.
It's certainly not going to lead to better health care outcomes by closing pharmacies. I think a lot of it has to do with how a lot of retail pharmacists are treated. There's a lot of burnout with staff, not only the pharmacists, but technicians. They're forced to administer vaccines, counsel patients, and, fill hundreds and hundreds of drugs each day. And so there is a lot of burnout in there. These corporations are having trouble finding staff, aren't able to keep their stores open. And then going along with the reimbursement rates from these PBMs that, yes, some of them are controlled by big pharmacy chains, but some of them are not. So you see the pharmacies as an individual getting squeezed by the low reimbursement rates on these ever-increasing prices on these drugs.
I'd like to invite Professor Sachs and the Attorney General to comment on the PBM experience that I've just described, any aspect of it.
Oh, sure. So in terms of the prices of prescription drugs, I'll defer on the question of independent pharmacies. In terms of the prices, there's clearly a role for some type of actor to negotiate for lower prices for drugs. But we've heard already about the ways in which PBMs don't seem like, in many cases, they're passing on the discounts that they're getting to insurers or to patients. And so in my view, we should think broadly about opportunities at the federal level and even at the state level for PBM reform. So you might have, for example, a regulatory reform or statutory reform that acts on the PBMs themselves, but you could think about a reform that would affect another actor in the healthcare system to push back on the problems that we're seeing. And so the Inflation Reduction Act, I think, is one example of this. So if you look at, for example, the Federal Trade Commission regarding PBMs and their conduct in the insulin market, one of the concerns is about patients' exposure to these really high out-of-pocket costs. You could respond to that, and maybe we should respond to that, by looking at the conduct of the PBMs themselves. But another way to respond to it is, as the IRA does, it caps Medicare beneficiaries out-of-pocket costs for insulin at $35 per month, and it has this additional out-of-pocket cap in the Medicare Part D program as a whole. So one option is to look at reforms that address the PBM itself, but another is to say insurers are working with the PBMs in this way, and that relationship is subject to some of these concerns that might be harming patients. Let's look at that harm to patients more directly. So that's maybe just one point I would make.
Attorney General.
Yes, Mr. Chairman. The transparency is desperately needed. As we initiated our first investigation into the PBM that I mentioned earlier, getting to resolution was rather quick because they knew what they were doing was inappropriate.
Inappropriate. From the Attorney General's point of view, might use a different word, but go ahead.
Yeah. There's stronger language that could be used. It's unconscionable because, as mentioned by several speakers today, the role of the PBM is the opposite of what the effect has been, is to be able to negotiate to drive down the costs, and the impact on end users, the patients, is that they're not using their medication, or they're not using their medication appropriately, and the consequence can be fatal in some instances. The question that we're faced with state actions to regulate PBMs is whether we're preempted by the feds, and that's why we've been trying to use both efforts to encourage and protect state efforts to control the pricing, as well as to encourage Congress to be able to get some transparency, get these PBMs to furnish their pricing data to the feds as well as state payers.
Ms. Brandt, as you described it, I'm impressed by the fact that you've been able to juggle all these numbers and how they apply to you personally. And you seem to have made it through this thicket, but you describe people who have not been able to do so. Do you think this notion of $2,000 a year maximum out-of-pocket expense, also define maybe $40 a week is the most that you can have to pay out of pocket. Do you think that this is a cleanup of a system that is too complicated?
It might be. I'm a person that charts everything. So every year I compare the medication programs and I write everything to how much every one will cost me. Not everybody does that.
I think you could be an influencer.
I'm yelling at people all the time. People have told me, oh, I don't look at it. I just pay the same, do the same. So I'm kind of yelling at them, but I think it's such a wonderful addition. The $2,000, I'm very, very happy.
It does make a big difference.
Big difference.
Dr. Sandsmark, when it comes to the role of the pharmacist, I think we ought to put a couple things on the record. What does it take to become a licensed pharmacist in the state of Illinois?
Usually about 6 to 8 years of schooling, and then
Beyond college?
That'd be total.
Pardon me?
Yeah, beyond high school, that'd be total.
So it's 8 years.
Yeah, depending on which school you go to, yes, it could be up to it.
Is it an expensive education?
Probably about $250,000 to $500,000, depending on which school you choose.
And ultimately, these pharmacists are still in high demand, right?
Very, very much so.
And how many pharmacy schools do we have in our state or nearby?
I think we're up to like 5 or 6 now.
Uh-huh. Yeah,
It used to be only a couple.
And you work out of the hospital, the Iroquois County Hospital?
Yes.
But you do retail?
We do everything. Might go from mixing a $100,000 chemo in the morning to filling a $4 antibiotic from a patient in our urgent care. So it's really all over the board.
Professor Sachs, I can't tell you how many times I've heard on the floor about the freeze innovation and preventing new drugs from coming to market. You teach a course on that, don't you?
I do teach classes on innovation in the pharmaceutical industry, but also on access to new medications.
The cancer drug Keytruda had $25 billion in sales last year, $25 billion. The revenue for this single medication is on par with what MasterCard or McDonald's Corporation earns in a year. How is it possible? How can it possibly be that a penny less in profit to big pharma will stifle innovation?
One of my favorite quotes on this topic is from former Health and Human Services Secretary Azar, who himself was a former pharmaceutical company executive. And he referred to this as a tired talking point, right? He said it's not the case that if 1 penny disappears from pharma profit margins, American innovation will grind to a halt. And yet, over time, we certainly have seen the pharmaceutical industry oppose all kinds of measures of drug pricing reform, from the larger scale drug price negotiation programs to much smaller scale bills that would focus on particular patent or FDA abuses. And so in my view, what we really care about is the value of innovation to patients. It's about delivering real new clinical value for patients and reforms that preserve and protect that value rather than just the amount of innovation are really what matters. And here, one thing about the Inflation Reduction Act, the IRA's drug price negotiation program, is it really centers that concept of innovation that delivers value for patients. So Congress specifically directed Medicare to consider, as part of the negotiation process, factors like whether a drug is a therapeutic advance as compared to existing therapeutic alternatives, the drug's comparative effectiveness, and whether the drug addresses unmet medical needs. Those are the kinds of things where Medicare is directed to consider whether this drug delivers more value for patients. If so, maybe we should pay more for it, rather than if there's a drug that's one of these, you might use the term Me Too drugs, but doesn't provide a new mechanism of action or a new option for patients.
We also know that pharmaceutical companies spend more in sales and marketing than they do on research and development. In 2020, Johnson & Johnson, one of the leaders, spent nearly twice as much on sales and marketing, $22 billion, as it spent on R&D. GlaxoSmithKline was even worse. It spent $7 billion on research and development. Less than half of the $15 billion is spent on sales and marketing. Dr. Douglas, you seem like you're aware of this. Have you discussed this with people in the pharmaceutical industry?
Yeah, certainly the uneven spending in terms of on advertising and marketing versus the actual research and development. I think that a common conversation amongst my own colleagues and around the hospital is the fact that in America we prioritize capitalism, right? And there's nothing wrong with turning a profit, but when that profit takes priority over people, especially in the healthcare industry, that's when it becomes a problem. And people are it's not an over exaggeration that people are dying because they can't afford the medications that they need, and they're spending much more time in the hospital and emergency department. When we look at you quoted the Johnson & Johnson numbers, Novartis spent $14.6 billion in advertising and $9.9 billion in research and development. Pfizer spent $11.4 billion in advertising and $6.6 billion in research and development. I have a hard time grappling why these numbers, well, one, why would your advertising costs be significantly higher than research and development, but why they would even be close in terms of numbers. And so I think that it is a moral hazard on the behalf of the pharmaceutical industry in order to turn over large profits. And, another point I want to make is that we talked about the evasiveness of the pharmaceutical industry in avoiding legislation to regulate these prices, and industries like the hospitals and some of our clinics, our larger scale clinics that get a lot of bad rap about care and affordability of care are being gouged by the pharmaceutical industry as well. We talk about the 340B program, which is currently under attack by the pharmaceutical industry and some other opponents of the 340B program. But those type of programs that make prescription drugs more affordable for hospitals and patients allow us to provide resources in strapped environments like at the University of Chicago, where we care for a large percentage of Medicaid and Medicare patients. So these programs that they've the legislation that they've evaded and the regulation that they have evaded from making prescriptions more affordable is harmful to patients, and it leads to less and less poorer outcomes in terms of healthcare outcomes in our country.
Now, the pharmaceutical industry is going to counter that they put these ads in the air for consumer education so that they can learn more about these drugs. I'm going to ask you about one of the drugs and one of the statements that's made over and over again. The drug Xarelto, the warning is this: don't take Xarelto if you're allergic to Xarelto. Tell me as a doctor, what you make of that?
Well, I think oftentimes in a lot of these advertising, we all see that the ads on the television about all the warning signs and how quickly they rattle off all the potential side effects or potential hazards to taking these medications, which is important for people to know and to be aware of. But there's evidently not a priority for people to know that. Otherwise, they wouldn't be the last 3 seconds of the commercial in these advertisements, right? So I think it's important. The transparency about the harm and the risk of taking these medications is important, but it's not a priority for the pharmaceutical industry, and it's a marketing tactic. There's a science to marketing, just like there's a science to medicine. And there, I think in one of the previous hearings you had, one of your colleagues on the Judiciary Committee talked about that the ads are a cure for loneliness, right? And how we look at these ads and the people start off as depressed and sad because they are dealing with the disease, and then at the end they're surrounded by family and loved ones
marching down the street.
Yeah. And that's not reality, right? It's a marketing scheme by the pharmaceutical industry to encourage and inspire patients to go and purchase or lobby their physicians to prescribe those medications.
Well, I kind of challenged the industry on consumer education when Senator Grassley and I introduced a bill which said that every one of these ads had to contain a disclosure of the actual list price of the pharmaceutical drug, so that the people who are watching this ad and thinking about maybe I can march down the street too, having lost 35 pounds. Maybe that's in my future as well. Well, we introduced this, and it turned out the pharmaceutical industry did not want to educate any American consumers on the actual list price they set for the drug itself. Do you have any idea what the number one advertised drug is on television now?
I'm not aware.
Well, when you hear the name, you will be. Rinvoq.
Mm-hmm.
Rinvoq. Any idea, perhaps Dr. Sandsmark, you might know this. Do you know what a monthly prescription of Rinvoq costs?
I don't think I've dispensed that one before, which is probably fortunate for my patients because I'm sure the prices can be rather high.
$6,100. $6,100. Now, if the ad were flashed on the screen while you're watching this ad, you might have second thoughts about whether or not I want to recommend that to the doctor next time I go in. Now, I don't want to stop anybody from a legitimate conversation and exchange with a medical professional. I'm not suggesting that at all. But this is not designed for legitimate information to be given to consumers. It is designed to market a product. Sure. And it's very successful in that effort and what they're achieving. I want to ask the Attorney General a question. When you join these other attorneys general on an amicus to the Ninth Circuit Court of Appeals supporting an Oregon law that requires pharmaceutical manufacturers to annually report information for certain types of prescription drugs, why is it important for the states to be able to provide more transparency?
Yeah, as I mentioned with regards to the PBM, having everything occur certain allows for inflated pricing and more transparency. Allows for state and federal regulators to rein in some of these practices.
Certainly does, and I think we've made that point today. Dr. Sandsmark, let me ask you about a specific pharmacy near my home in Springfield. I've heard concerns from independent rural pharmacy owners like Dave Baggett, Petersburg Pharmacy in Menard County. He's highlighted the systemic underpayment by PBMs to small pharmacies and how these middlemen steer patients to their preferred networks. The Federal Trade Commission has also found the same thing in enforcement against the three big PBMs, CVS Caremark, Express Scripts, and Optum, for anti-competitive and unfair rebating practices. This is a complicated subject, but I'd like to ask you and Professor Sachs. We need more transparency around PBMs, as the Attorney General just said. Can you help us unpack these issues?
So first of all, Preferred pharmacies is a loaded term, right? So preferred doesn't mean more affordable. It just means that the PBM wants you to go there. It doesn't mean you're going to save money there. Even on the Medicare Part D website, patients can go and see that one insurer might say that a chain pharmacy is preferred. But if they were to select a small independent pharmacy like the one you talked about, that pharmacy might not be preferred, but more affordable for the patient at the bottom line annually. So you have to see who's calling it preferred, right? Is it the PBM calling it preferred? That's steering you towards that. And we see the low underpayments all the time on these brand name drugs that we've been talking about all morning. Those are the drugs that a lot of times we're losing the most money on, right? The independents are. So 20% of our prescriptions each month, we're usually losing some amount of money to the PBMs because they're not paying us enough for what we're paying it from the wholesaler.
So they make the drugs available, but they charge prices which you can't recover at the counter.
Yep, exactly.
Professor Sachs?
So one, I think, of the real challenges here, and we've heard a little bit about this, is the role of vertical integration and the ways in which these PBMs are incorporated into pharmacy chains or insurers or other parts of the drug pricing supply chain and ecosystem, which makes transparency particularly important, but also even more complicated. So we heard already, for example, reference to this New York Times series about the role of PBMs. Something that comes up in that series is about the role that PBMs are now creating these GPOs, these group purchasing organizations that they're separating out from their core PBM functions, and whether through those GPOs they might be siphoning off additional fees or other services. And it's very difficult to know. And so transparency or sort of other oversight in general might be helpful in getting at that information. Another point that comes up in that news series and also in the interim staff report from the FTC from earlier this summer is this question of PBMs now introducing their own co-branded biosimilars, and in some cases preferencing them over biosimilars from other manufacturers. That's something where there also has yet to be, I think, a real sustained look at whether that's pro-competitive or anti-competitive. And so there's a whole range of practices that have been raised in these reports that it'd be helpful to know much more about.
It appears there's another process underway. Some of the largest pharmaceutical companies have gone further. They have launched new telehealth platforms. Now patients seeing a drug ad on social media can, quote, click here to talk to a doctor about a company's advertised medication. These platforms link patients with hand-selected healthcare providers. The ensuing visits are often brief with little to review of health records or histories. It makes a healthcare appointment more like an Amazon shopping experience. And the financial relationship between the drug company and the doctor raises concerns about inappropriate inducement of prescribing. What concerns would you have about pharmaceutical companies' hand-picked doctors writing prescriptions for patients who are connected via their own ads? Dr. Douglas?
Yeah, I would have significant concerns. There's financial incentive for these physicians to prescribe medications that may not be the most appropriate for that patient's situation. So I certainly, I'm not personally aware of any physicians who are employed or work through telehealth and are supported through prescription drug industries, but I certainly would be concerned that there's incentive for the physician to prescribe medications that won't necessarily benefit the patient or be appropriate for their situation.
Professor Sachs?
Well, as a health law professor, something we talk about often is the independence of the medical profession and the importance of physicians being able to make independent medical judgments based on clinical evidence about what might be best for their patients. And so there's a whole series of different laws that are designed to make sure that physicians are exercising that independent judgment, maybe that they're not being financially induced, right, by other actors. And so I'd have to look more at that case study in particular, but that certainly would be something that would be potentially concerning in thinking about the role of the physician and their relationship with their patient.
I want to thank this panel for their contributions to this hearing. This hearing has really laid out in real terms how the market failures caused by Big Pharma's exploitation of the patent system and bombardment of TV ads have made medications unaffordable for many people. The perspectives we heard from patients, pharmacists, providers, and legislators are a call to action from my point of view. We need to build upon the Inflation Reduction Act. For Ms. Brand's observation, we've got to have affordable drugs. Your money or your life is not an acceptable outcome from this hearing. The perspectives we heard today help us to build upon that aura and bring down the high cost of prescription drugs. I'm not against pharmaceutical companies making a profit. I'm for it. I wanted to incentivize them to find new cures, new approaches in medicine. What we have now in this country is just almost indescribable. Try to get somebody to describe the role of a PBM. Attorney General, there was a full-page ad in the New York Times not that long ago from the PBM industry saying, we're not middlemen. I thought they were middlemen. Completely lost the role that they play. We need to continue to incentivize pharmaceutical companies to develop these drugs while ensuring that they're accessible to Americans who need them at a price they can afford. The hearing record will remain open for a week for statements to be submitted. Questions for the record may be submitted by senators by 5 p.m. on Tuesday, November 5th, a day you should remember. I want to thank the witnesses again for coming. This hearing stands adjourned, and that's the end of your vacation, Ms. Brandt.